So I have a disclaimer that I'm not a skull-based neurosurgeon, and this will be a bit different. I like to joke with Art, especially, that it's actually brain surgery, not around the brain surgery. And there's very few things in neurosurgery that really get you up close and personal with cortex. So, this question of eloquence, I think, no one really knows what it truly means. It was a term used by Spencer and Martin actually to describe AVMs and to describe their location in certain regions of the brain, but it's never really explicitly defined. And I would say that, for most of us, in training and in early years of practice, if the patient's able to go home, talking to us, conversing, they're fine. And so the gross functions have been motor, speech, and vision. But of course, the patient in the real world and the patient when they come back to see you in clinic has many, many more subtleties of language comprehension, production, reading, working memory, episodic memory, cognitive control, and of course, when you talk to their family, their personality. And so really, I'm not going to pretend like we can talk about all of these functions today. We'll talk about a few and try to convey how we in our practice try to maximize the preservation of these functions. And of course, all of this is important because there's clearly this tension in glioma surgery between maximum resection and functional preservation. And really every case exhibits this tension. There's plenty of data. It was initially this idea that you had to have 98%, and the number changed to 78%. And now the number is even higher. It's more than 100%. This idea of a supramaximal resection. We published this paper now many, many years ago with my partner now and then resident Joshua Eskenazi to say you should go beyond the tumor to the next peel boundary, and that actually correlates with a better outcome and minimizes the early recurrence in these tumors. Further, many tumors that I see and many tumors that many of you may see are epileptogenic. These people are making seizures in addition to having a mass. And you're dealing with two problems. There's an epilepsy problem and a tumor problem. And, it becomes a question of, where does the epilepsy end and where does the tumor begin? And of course, it's very clear that there are some things that are purely epilepsy and some things that are purely tumors. But then there's this entity in the middle, which, there's many eponyms for it, where again, the same concept of maximizing the resection correlates the best with seizure outcomes. We talked about this a few years ago, where really an aggressive initial resection and then a re-resection in the context of recurrence and even radiation therapy all play a distinct role in minimizing epilepsy in patients with gliomas. So this entity that some people call LEATs, or low-grade or long-term epilepsy-associated tumors, or tumor-related epilepsy in low-grade tumors. No question, the more you take, the better patients do. But the more you take, the more deficits you get. And the brain is not balanced, and therefore, like the careful surgeons that we all are, we want to make decisions that are balancing functional preservation and optimizing benefit. Of course, this is exemplified by the work of many neurosurgeons, especially this beautiful book by Henry Marsh, that increasing resection volume at the expense of causing new permanent deficit really nullifies all the survival benefits that you may convey from your surgery. So I'm going to go back now about 100 years to talk about how this whole field came about. And it really came about from epilepsy. On the top left here is a neurologist named Ottfried Foster, who was a neurologist at the end of the First World War in Germany. It was fashionable in that era to wear berets. Young men got shrapnel in their brains. They developed epilepsy. There was no drug for epilepsy, not a single drug. Phenobarbital had not been invented yet. Lithium was the only thing available. It was a terrible drug. And so Foster, in frustration, sent these patients for resection. The surgeons uniformly killed the patients. And so he decided he would become a neurosurgeon himself and started with the idea of doing awake mappings. And a few years later, a young man from the US at that point, Wilder Penfield, decided to go to the Rockefellers, ask for money to travel to see Foster, learn how to operate. And that's how mapping became mainstream in North America. Many gentlemen later, you could talk about George Ogerman, Mitch Berger, several folks then took that tradition of mapping and have made it really mainstream in what we do. And of course, there's some basic prerequisites. We can't map everybody. You have to have people who are calm or able to stay still, patients who understand the goals and do this with you. And most of you have seen this sort of setup. The patient's on the side, we inject local anesthetic, open the scalp, infiltrate the dura, and then the patient's awake. And once the patient's awake, this is the view from the other side, and the anesthesiologist can do their part and you can do yours. So there's just a few videos here. I'm going to skip this one actually to get to this point that thus far, this is what we've done. We've come up with these kinds of maps, which are really in some ways cartoons drawn from the experience of many, many surgeons using pictures, sometimes even using stealth snapshots in the operating room to create these representations. And these are then used to create something that looks like a map like this. And, we argue that we should be able to do better. So here's an instance of a gentleman with a Broca's area tumor. I don't know this. Can I get audio? Is there audio?
Can we get him audio? Do you need a cable connection or?
Yeah. I'll just put my microphone down.
That meows.
Oh, yes. No.
Your volume is maximum.
It is, yeah. Okay, well, you get the point though. Generally, this is the way mapping gets done. And then this is the same individual, right? So this is a mass in not just in Broca's area, but extending into subcentral gyrus. And in fact, some would argue that it's really in subcentral gyrus, pushing Broca's area anteriorly. This yellow spot is the speech arrest site. There's face motor cortex, again, since it's subcentral gyrus. And then there's hand motor just dorsal to this. And then there's language in the superior temporal gyrus. So our idea is that you should take this current that you inject into the brain and represent it not just as a point, because current doesn't stay static, it propagates on a cortical ribbon. We spent some time trying to understand how the mammalian brain responds to stimulation, what that spread function, if you will, should look like, and then constrain that current into the cortical ribbon or the little band of gray matter where the current is most likely to be. This is just a representation of that schematically to show where the point of stimulation would be and then what the effect would look like. And the same individual that I've just shown you, then we can take these points and then create a map that looks like this. This is actually, if you will, a most likely region of immediate depolarization produced by stimulation. We then aggregate data across people using something called surface-based co-registration, which minimizes the possibility of errors and deformation to come up with what looks like population maps. I'm going to skip this. This is just a basic glossary of the terms that we throw out. I'll try to explain them as we go along. And then the other big part is, I said earlier, we don't just want patients to walk and talk. We want to be able to do better. And so our typical paradigm in the operating room includes these four tasks, and then others based on location. Picture naming, which goes back to Penfield and Foster and Ogerman, and sentence repetition also goes back all the way. But then two other tasks, auditory naming, where they listen to the description of something and then repeat it.
A wild animal that eats bananas.
So the patient would say monkey, and then the same thing, they would see single letters on the screen and use that to map both reading and language production.
Bananas.
So when we do all of this and put this together, and one of the advantages of doing this over some length of time is this is now 243 mapping sessions in 200 adult patients collected over the better part of 15 years, we can come up with maps that look like this. And these maps are useful in many, many different ways. The first is, you can see now that if you look at these different paradigms, auditory naming, auditory repetition, visual naming, it's very clear that these two latter tasks are almost entirely subsets of the first one. So we don't need to do all the other tasks. And we realized this about 5 years ago, that auditory naming is a really comprehensive task that maps the language system very expediently. The second thing that you notice is, well, there's Broca's area, there's superior temporal gyrus. Well, what's this big spot here? And we'll talk about that in a minute. That big red spot there that I think is very understudied, under-recognized brain region for language. And then this region on the ventral surface of the temporal lobe, which again, most of us don't think about and don't cogitate about as being too important. Now, of course, sanity check for the same individuals. Here's motor cortex, right? Localized the same way from these 230-odd mapping sessions. It's concordant with where we'd expect motor cortex to be. Same with vision. It's concordant with what the occipital lobe is. So that makes sense. So let's dive in a little bit deeper. So here's the naming to definition or auditory naming. And you see this region in the posterior middle frontal gyrus abutting the superior frontal sulcus that that is a region of language engagement and involvement. And when you make a conjunction map, you see that this looks like this. This region, which we now call the dorsal language area, we've stimulated in 26 patients in whom we stimulated it, and 65% of those individuals, this site was positive. And here's a video to show you what this sounds like and looks like.
The organ that pumps blood.
What is the organ that pumps blood?
You can hear the patient repeating. He can speak just fine,
Blood, a vessel,
but he cannot retrieve the right word.
a heart.
There you go. What is the thing that unlocks a door?
Door lock.
So we call these semantic paraphrasing errors, where he has the concept, but he cannot access the word.
Here we go. Tell me an animal that meows.
Cat.
Good. Something you wear on your feet.
Shoes.
Something you wear on your head. And I want you to say it exactly as
And
I
so you
say
end
it.
up with a map that looks like that. This area has been talked about a little bit in the past in some contexts, but no one seems to have really focused on it. And really another way of thinking about it is it's right adjacent to frontal eye field, hand motor cortex. It's distinct from the dorsal language cortex that Eddie, Chang, and others have published about before. And it's not a simple articulation of phonology site, but and it's also borne out by our work with recordings as well. Separately, we talked earlier about the ventral site of the temporal lobe. So we're interested in reading. You saw another paradigm where the same individual was looking at words flashing on a screen, coming up with answers. And it turns out there's a distinct region for reading in the ventral temporal cortex, which again, in our training as neurosurgeons, we barely appreciate. So here's an individual with implanted electrodes in the epilepsy monitoring unit. I'm going to just jump through the more important part here.
A fence can provide a border around a property, yes. Many people place pictures on the floors of their home. No. Keep reading, my dear. The rainbow is a division of white light into many colors.
What's going on? Tell me.
I can see it. I don't know how to read.
So this is the production of dyslexia in an adult person just by stimulating this one small focus in the midfusiform cortex. We've put this together along with the areas that have to do with face recognition, and it's right next door to the cortical representation for face naming. You can see here a compilation across a relatively large cohort of almost 50 patients, where in yellow here are sites that are common to both visual naming and reading, and in red are sites that are unique only to reading. And when you create a heat map, you see that the reading sites are just posterolateral to these naming sites in ventral cortex. Many of us understand that there's naming there, but the reading emphasis is really important. We've also shown that in our own cohort of temporal lobectomies, in those individuals who came back for follow-up neuropsych testing, and we did a probability estimate of which parts of the brain's resection leads to a naming deficit, this is actually divergent from what I was taught, that the superior temporal gyrus is what you want to save. Don't take out the STG, you'll produce a language impairment. It's actually this part of the brain that matters. The STG resection does not correlate with the amount of naming decline that individuals have.
1 minute.
Thank you. I'm going to just show you quickly that when you take data from implanted electrodes instead of stimulation now. And this is a large cohort of 134 patients. And they're just doing a very simple naming task, just like Ogerman's task. You end up with activation maps that show you the same regions of the brain. This is a heat map of activation, naming single pictures in this large cohort. And when we put these maps together, here's the gamma power estimate from this large cohort. Here's the stimulation mapping estimate. All of these regions are actually well represented. Don't be mistaken by the color. That is just a question of when that area is active relative to articulation. And as you can see, all the areas in blue are the areas that you would think of are true language areas. The white areas are the speech areas, and the red areas are the areas that listen to the individual speaking. Of course, we can use this to map music. I'm going to skip this in the service of time. Just a person playing keyboards. We can map where music lies. Just jump to this part, which I think is also important and ties in with our last speaker, that it's not just important for us to understand the cortical representation. This is a highway map of North America, and there's no cities on here. But the reason that these highways exist is because there's important things between them. And it's the same with the brain. And we have sought for a long time to combine our cortical maps with well-known underlying pathways. So in this case, the arcuate fasciculus, the inferior longitudinal fasciculus, the occipitofrontal fasciculus, and these fiber pathways actually connect to these salient sites in the brain. You can obviously bring that data to the operating room, produce the same language impairments that you did with cortical stimulation by subcortical stimulation, and then export all that data as well to create population maps of white matter that is essential for language. I'm not going to belabor this part. Let's jump through this to get to the point that you can then selectively stimulate these pathways and produce selective deficits and show that these pathways correlate extremely well with the essential language sites above them. Here's an example. This is a young man who's around 14 years later with this low-grade glioma right in motor cortex. And of course, this little residual, I operated on him 2 more times. All of the signal change you see now is really the unfortunate effects of radiation that he's sustained, but he's still doing well. Similar instance, this was a rancher with seizures, large insular glioma. The part that is important here is the retrolenticular fasciculus, the white matter fibers behind the basal ganglia that you cannot damage. And localizing them, preserving them, stimulating them can lead to really, a good resection and an outcome, that is both good for seizures as well as for survival from an oncological standpoint. And I'll jump through this last case, just leave it. And just to thank all of my people in my lab who've helped make all these pictures and with data analysis over the years. Thank you.